Hello, and welcome. Today we're diving into a complex and fascinating area of neurology, paraneoplastic myasthenic syndromes. These are rare autoimmune disorders that arise as a consequence of cancer, specifically affecting the neuromuscular junction, where nerves communicate with muscles. We'll explore what causes them, how they impact the body, how they're diagnosed, and what treatments are available. So, what exactly causes these syndromes? The root lies in the body's own immune system. In paraneoplastic myasthenic syndromes, the immune system, triggered by the presence of cancer, mistakenly targets proteins at the neuromuscular junction. This is usually associated with small cell lung cancer, or CLC, but can occasionally be linked to other types of tumors. The cancer cells express proteins that are similar to those found at the neuromuscular junction. The immune system, trying to attack the cancer, ends up attacking the nerve-muscle connection as well. Let's delve into the pathophysiology. At the neuromuscular junction, the nerve releases acetylcholine, a neurotransmitter, which binds to acetylcholine receptors on the muscle cell, triggering muscle contraction. In Lambert-Eaton myasthenic syndrome, or LEMS, a prominent paraneoplastic myasthenic syndrome, the immune system attacks voltage-gated calcium channels, or VGCCs, on the nerve terminal. These VGCs are crucial for calcium to enter the nerve terminal, which is needed for the release of acetylcholine. When VGCs are damaged, less acetylcholine is released. Consequently, the muscle cell receives insufficient signal, leading to muscle weakness. Similar autoimmune attacks can target other proteins vital for neuromuscular transmission in other paraneoplastic myasthenic syndromes, disrupting the communication pathway. Paraneoplastic myasthenic syndromes are relatively rare. LEMS, the most studied, affects approximately 3 in 1 million people. Because these syndromes are linked to cancer, their occurrence is influenced by the incidence of associated cancers, particularly small cell lung cancer. It's important to remember that not everyone with small cell lung cancer will develop a paraneoplastic syndrome, highlighting the complex interplay of genetic and environmental factors that contribute to their development. The hallmark of paraneoplastic myasthenic syndromes is muscle weakness. In LEMS, weakness often begins in the legs, making it difficult to climb stairs or walk long distances. Characteristically, muscle strength may improve briefly with repeated effort, a phenomenon known as incremental response on nerve conduction studies. Other common symptoms include dry mouth, constipation, and erectile dysfunction, all related to autonomic nervous system dysfunction. Some individuals may also experience double vision or drooping eyelids, similar to those seen in myasthenia gravis. Diagnosing paraneoplastic myasthenic syndromes requires a multifaceted approach. Electrophysiological studies, such as repetitive nerve stimulation and single-fiber electromyography, are crucial in identifying the impaired neuromuscular transmission. Blood tests to detect specific antibodies, such as anti-VGCC antibodies in LEMS, are also essential. A chest CT scan or other imaging studies are performed to search for underlying cancers, especially small cell lung cancer. It's the combination of these findings, clinical symptoms, electrophysiological abnormalities, antibody presence, and cancer detection that leads to a definitive diagnosis. While the term paraneoplastic myasthenic syndromes encompasses a group of related disorders, Lambert-Eaton myasthenic syndrome, or LEMS, is the most well-defined and commonly discussed. Other less frequent syndromes may involve different antibody targets and present with slightly different clinical features, but they all share the underlying mechanism of autoimmune attack on the neuromuscular junction in the context of cancer. Treatment for paraneoplastic myasthenic syndromes focuses on two key objectives: treating the underlying cancer and managing the neuromuscular symptoms. Cancer treatment, which may include surgery, chemotherapy, or radiation therapy, is critical to suppress the immune trigger. Symptomatic treatment includes medications that enhance acetylcholine release, such as amifampridine, and immunosuppressants like prednisone or azathioprine to dampen the immune response. Intravenous immunoglobulin, or IV, and plasma exchange are other options to provide short-term improvement. Lifestyle modifications, such as pacing activities to avoid fatigue, are also beneficial. Currently, there are no proven methods to prevent paraneoplastic myasthenic syndromes directly. However, early detection and treatment of associated cancers, particularly small cell lung cancer, may potentially reduce the risk of developing these syndromes. Promoting healthy lifestyle choices to reduce cancer risk, such as avoiding smoking, is also important. The prognosis for paraneoplastic myasthenic syndromes varies greatly depending on the type and stage of the underlying cancer, as well as the individual's response to treatment. Early diagnosis and aggressive treatment of both the cancer and the neuromuscular symptoms can significantly improve the outcome. Research is ongoing to develop more targeted therapies that can selectively suppress the autoimmune response without causing widespread immunosuppression. Novel immunotherapies and targeted cancer treatments hold promise for further improving the prognosis and quality of life for individuals living with these complex syndromes.